So, assalamu alaikum, good morning, everyone. I know it's a bit early, so you might not be awake enough to be solving questions, but we'll try our best to make this chapter as simple as possible and as exam focused as we can, so that when you enter the exam, you know exactly what to look for and what exactly to answer. Before we start, quick introduction. I'm Malak Khaled, and today Zarlala and I will be taking you through this chapter. It is quite heavy, but again, we'll try our best to make it quick, and inshallah, we'll have a break around Dhuhr, so you guys can refresh and come back for physiology. So, quick session outline. We've split it again, anatomy and physiology. I'll be giving you the external anatomy part, and then Zarlala will take over for internal. And then I'll be going through conduction and cardiac cycle, and then Zarlala again will give you the stroke volume, heart rate, and cardiac output physiology bit. Okay. Again, I'm starting very straightforward. We're going to start with a question. So if you guys haven't scanned the code from the first one, you can scan it again. If you've already scanned it, it should show up for you on your phone or whatever you're using. The question says, a 25-year-old man is brought to the emergency department after being stabbed in the chest during an altercation. The entry wound is located just left to the sternum at the 5th intercostal space. He is hypotensive and has signs of cardiac tamponade. And based on his presentation, which cardiac chamber is most likely to be injured? If this is not working for you, by the way, you can use the chat. Or you can open your mic and say the answer, whatever you're comfortable with. Okay, for the sake of moving forward, the answer to this question is the right ventricle. Now, why is it the right ventricle? We're going to see soon with how the heart is oriented and placed inside the thoracic cavity. So when you're thinking about the heart, there are three basics that you shouldn't forget: the size, the location, and the orientation. The size, we all know it's fist size. Location and orientation, we'll see it soon. But before that, when you're asked to draw a heart, right, or you ask someone to draw a heart, they usually go ahead and give you this. And we know that this is not the most accurate representation of how a heart should look like, right? Now, there are two things to consider on how we want to orient and locate this heart in the thorax, right? Two things to consider. We want to tilt the heart to the left, and we want to rotate it so that the right side faces anteriorly. And because the right side faces more anteriorly, that is why in the question before, when you were asked about when the man was stabbed, what is most likely, which chamber is most likely to be injured, it's going to be your right ventricle, because it's the most anterior to everything else, right? All right. This is a quick diagram to help you visualize how it looks like. And the heart is cone shaped. So just like any cone, it will have a base, a flat base, and a pointed apex. The flat base is, if you put this in a person, the flat base is towards your right shoulder, and the apex is towards your left hip. Now, the heart is not alone in the thoracic cavity, of course. It has more organs around it, right? So for example, we have lungs. Where are the lungs going to go? The lungs go around the heart on the two sides, right and left, right? They're in the thoracic cavity, but again, to be more specific, because you took the orientation chapter, right? So the heart is in the mediastinum, specifically in the pericardial cavity. And the pericardial cavity, again, is inferior to the superior mediastinum. Now, we also have a diaphragm. Where does the diaphragm go? It will go under the heart. So in, again, your orientation, the anatomical terms, we'll say that the diaphragm is inferior to the heart, or the heart is superior to the diaphragm. It sits right on it.
Malak?
Then we also have, yes?
Sorry for interrupting, but there is a question in the chat box.
Oh, okay. Why was it the right ventricle? Okay, basically, when you get your heart and, okay, wait, it's lagging a bit. Okay, you get your heart, you get any object and you place it flat, right? This is, you divide it into 4 quadrants. If you take this object and you rotate it a bit to the left and you tilt it, so the right side is facing more forward, okay? You could do this with your phone, by the way. You can put it like on your chest and then rotate it to the left and then tilt it forward a bit. So one side is always going to be facing more forward. So when you get, for example, any object, if you get stabbed, la qadar Allah, but if that happens, the chamber that is most front will get injured the most, right? So that is your right ventricle. Does that make sense? Okay, awesome. where were we? Yeah. So again, at your thorax, you don't just have the heart, you have multiple other organs. So your lungs, your diaphragm, we've already discussed these, and you have your rib cage and sternum. So the sternum, the rib cage needs to protect your thorax, right? So by logic, if the sternum is the most anterior organ or the most anterior part of your body, right, then it will cover over your heart. So the sternum is anterior to the heart. And then lastly, your vertebral column. So the vertebral column needs to support your back. So ultimately, it's the most posterior thing to your heart. So vertebral column, most posterior to your heart. This is a diagram. It is not in your textbook, but if it helps you visualize where the heart is located, then that's great. Then we again have more location-related information. This is a transverse section. I think you are familiar with it by now. And if none of the location things make sense to you at all, this is a map of the medical campus, and it's annotated to match how the heart's location is within the thorax. So if none of this makes sense to you, at least hopefully this will make sense. Moving on, we have another question. Do you guys want to answer this, or do I answer it? Okay, so a 50-year-old patient is suffering from cardiac tamponade. Again, the physician treated him by removing the excess fluid using a syringe. Which of the following is the correct order of the names of the layers that the syringe needle will pass through? And by the way, this is a very common question, not only in the heart chapter, but also you might take it when you take lungs. I'm not sure if you guys did it or not. But anything where there's layers, they might ask you a question like an object went through all these layers. What is the order that they go through? Okay, we have parietal, then visceral, then fluid cavity, or fibrous pericardium, parietal pericardium, and then the fluid cavity. Well, honestly, the second question B is not wrong, but the most correct answer would be to go through the fibrous pericardium and then the parietal and then the fluid cavity. I'm not sure why parietal pericardium to visceral to fluid cavity was an option, but the most correct one would be fibrous pericardium. Why? Because the most, like the highest, and then you go to the next layer, and then you go to the next layer. The other options don't include fibrous pericardium. This is a quick summary to like summarize all the coverings. I'm pretty sure that this is a simpler topic because you did tissue before, so you know how serous membranes work. So I will not go over this part. Then we have another question where a patient presents with chest pain, shortness of breath, and dizziness. Further investigation reveals a large amount of fluid in the pericardial cavity. What is your diagnosis? We have hypertension, pericarditis, pleurisy, and cardiac tamponade. Okay. Yes, okay. So cardiac tamponade is correct. And we'll see the difference between cardiac tamponade and pericarditis now. So if you see anything with itis in it from your English course, you probably know it means inflammation. So in this case, your pericardium, the pericardial serous membranes, get inflamed and it roughens the surface of the membrane. This gives the person pain that's deep to the sternum, and then it causes pericardial friction rub. So I don't want you to confuse pericarditis itself with the sound that is heard because of pericarditis. So the sound is a pericardial friction rub, and it's a creaking sound heard when you auscultate a person with pericarditis. Now, for cardiac tamponade, it's completely different, right? It's fluid accumulation. Now, the word tamponade comes from tampon, which is a plug. So it's literally heart plug. It stops your heart. It like limits its ability to pump blood. And for treatment, as mentioned in the question before, they just use a syringe and they drain out the fluid to help the heart get the space again. Okay. One more question about layers. So this is about your endocardium. It's not very common to get questions about the layers, but when they do get questions about layers, you really need to know all the properties so that you don't confuse anything with the other. Like you might skip over it and think that, oh, okay, like layers are so easy, but they can get a question with like all the possible properties that this layer can have, and you'll get confused. Okay, Do we have answers? Okay, I actually confused. I got confused and I picked this answer before, but it's actually a continuous lining with the blood vessels. Why is it not the option that you picked? It's because it says connective tissue. So the endocardium is a serous layer. It is not connective tissue. So it's simple squamous epithelium, right? It's not connective tissue. That's why that answer is wrong. Okay, moving forward. Another question. 22-year-old man presents with retrosternal pain during exercise that improves with rest. Examination and initial ECG results suggest transient myocardial ischemia due to reduced coronary blood flow. Which layer of the heart is most directly affected by the decreased oxygen supply? This question is taking you on a journey, and at the end, they're just asking a very simple question. And they do this a lot. There will be a huge scenario at the beginning, and then you get hit with the simplest like prompt question at the end, and you just wasted your time reading the scenario. So, I mean, it has some keywords, your chest pain and myocardial ischemia. But honestly, if you just read the end part where they're asking what is the most like chamber that's what's the most affected layer by this, it's the myocardium because it's the contractile and metabolically active layer, right? Okay, quick review of your myocardium and cardiac skeleton. So myocardium arranged in spiral circular arrangement. The function is to contract so that your heart can pump blood, right? And then you have your cardiac skeleton. Now this is very, very important, and we'll see later why in the conduction, right? The function here, you have your spiral arrangement, but there's nothing to keep the spiral arrangement in shape, right? Like if you just leave a spiral, if you turn a ribbon around and you leave it, it will undo, right? So you need something to reinforce this to keep it together. You have your cardiac skeleton. Cardiac skeleton will keep it together and also support your openings of valves and blood vessels. And this is important because if you don't do that, right, your valves will become stretched, your blood vessels will become stretched. And the last and most important one, which is insulation, and we'll see this why in the conduction system. This is a quick summary. So again, fibrous is the most top layer of your coverings, and then you have your serous membrane, so your parietal and your visceral, and they loop around their continuous layer, and then you have your myocardium for pumping, for the cardiac activity, right, pumping activity, and then your heart chamber that is lined with the endocardium that is continuous with your blood vessels. Okay. One last question about the layers. Which of the following layers of the heart house the coronary blood vessels? This is a bit confusing because when you think about coronary blood vessels, you think about how they supply the myocardium, right? So you might pick myocardium thinking that it's the right answer, but it is not. So the right answer here is, it's an interesting choice. Okay. Oh no. Okay, the answer is the epicardium. Why is it the epicardium? We'll see in the next slide. Okay, so it's the epicardium. Why? Because you have, like, you know, when you have pipes in your house and you have your bathroom, okay, you're not seeing all the pipes running around in your bathroom, right? They're hidden outside, and then they just go in to supply your sink, for example. So for the heart, it's the same thing. Your coronary vessels are in the epicardium themselves, and then when they need to go to the myocardium to supply it, they go to supply it. Okay. Now, that was a nice segue to our coronary circulation. So to master your coronary circulation, you need to know the grooves of the heart. The heart, for you guys, will have two grooves, sorry. So you will have your coronary and your interventricular. It's like a crown and a medal, okay? The heart is a winner. It has a crown, the coronary sulcus, or the coronary groove, and then your interventricular groove, which will be the medal. Okay, now we've built the house, right? Anything that will come inside it will be easy, inshallah. So Did you guys ever play these games where you connect pipes? So you start from a main source and then they want you to get the whatever water to the other sources, right? So in these cases, we have our main source. Same thing in the heart. We have the aorta. Okay. Now, if you want to go to any location, let's say you have your ventricles, your septum, your posterior side of the heart, the lateral side of the heart, and then the posterior side, the posterior ventricles, right? What are you going to do? If you want to go to the right side, it's simple. You'll just take the right coronary artery. If you want to go to the left side, you'll take the left coronary artery. Very easy. Okay. Where it gets complicated are the small branches. So let's say you want to go to the anterior ventricles and the septum, okay, which is this vessel running down here. It's named very simply. If you want to go to the anterior side, you will take the anterior interventricular artery, right, between the ventricles. Or it's also called the left anterior descending in clinical cases, okay? And then if you want to go more posterior, you want to cover the rest of the ventricles, right? You've covered the anterior surface, but you still have a bit of the lateral side, and you also have your atria that didn't get any blood supply. So you'll take the circumflex, okay? We're done with the left side. Now we want to go to the right. So if you want to go more lateral, now lateral and marginal go very well together, right? It's easy to remember. Now, if you want to go posteriorly, again, posterior interventricular artery. You covered the entire heart now. And remember how the the interventricular sulcus was a medal? So same thing here. These two guys, the posterior and the anterior interventricular, are anastomosing. They're connecting at the apex, which makes them form a literal medal around the heart. So that's all for coronary. Let's see if you guys anything out of that. Which branch of the right coronary artery? Which of these is a branch of the coronary artery? The right one. Okay. Yeah. It is the posterior interventricular artery. Awesome. Moving on, we have your veins. If you get your arteries right, your veins are very easy. You just have three draining into one. So you have one final destination, okay? That final destination is your coronary sinus. It's gathering everything. So grade, middle, and small will drain into the coronary sinus. Very easy to remember. And a question about that. Okay. There was only one that we didn't mention here that wasn't one of the veins, which is the anterior cardiac veins, yeah? And they directly, oh, middle. That's an interesting choice. Okay. So grade, middle, and small drain into the coronary sinus. Anything else, which are the anterior ones, the small guys, they drain directly into the atria, the right atrium. So they don't drain into the coronary sinus. That's basically the rationale that you should have while answering the question. Okay. Now, the most important thing that you need from this whole discussion about coronary vessels is your pairings. So what vein goes with what artery in which sulcus of the heart, okay? Now, the great cardiac vein always goes with the anterior interventricular. It's great. It's taking from the great chambers, the ventricles, right? With the anterior interventricular artery. And anterior goes with anterior and interventricular goes with interventricular. So easy to remember, right? Middle cardiac will go in the back with posterior interventricular. And the coronary sinus, like the crown, will go with the coronary sulcus, again, around the heart like a crown. Okay. One last question about coronary vessels, I believe, and then you will be off with internal anatomy. So a 40-year-old man presents to the clinic with chest pain. After examination and investigation, the doctor described the pain as angina pectoris. Which of the following is true regarding this case? I've helped you guys out a bit with underlining the key words. Okay, so the answer here Okay. The question was a bit loopy. It's like but it's a very direct clinical scenario, right? From your homeostatic imbalance, anything angina pectoris, think of your heart is not getting enough oxygen, right? You're not getting enough oxygen, you might be having a blockage in your coronary artery. This can be stress-induced or because of increased in demand, that he's like feeling the pain, right? But in this case, your heart cells don't die, right? They only die when this is prolonged. If it's prolonged, if they don't have oxygen for too long, then you might have a myocardial infarction. Infarction is death of the cells, and this will lead to a heart attack. But in his case, he does not have prolonged oxygen depletion, so it wouldn't be myocardial infarction. And that's all for the external anatomy. I'll leave you with Zarlala for internal anatomy.
Can you guys hear me?
Yep.
Okay. Hello everyone, I'm Zarlala and I'll be talking about the internal anatomy of the heart. So how each chamber looks like on the inside. So we'll start with a question. Next, please. Yeah. So which of the following is correct regarding the cavity of the left ventricle? You can answer in the chat box or you can open your mic. Okay, so for the sake of time, I'll just move forward. So basically, why the answer is it shows two openings. So why is it like that? Let's go through each option. So the first option says that it shows three papillary muscles attached to three cusps of the AV valve. Now on the left ventricle, we have the mitral valve or the bicuspid valve. So that has two cusps, meaning that it has to have two papillary muscles and not three. Therefore, option A is wrong. Then the second option says that its wall is thicker than the left atrial, but thinner than the right ventricular wall. And that is also wrong because the left ventricle has a thicker wall compared to the right ventricle, and we'll see why in the next slides. Then it shows two openings. That is correct because its first opening is from the atria to the ventricle. There's an opening there. And its second opening is from the ventricles to the aorta. So that's the second opening. So option D is wrong because it says it is crescentic and wraps around the right ventricle. It's actually the opposite, and we'll see again in the next slides that it's round and not crescentic. So next slide, please. Okay, so the functions of the atria and ventricles, I'm sure you're all familiar with that. Atria is receiving chambers, ventricles are pumping chambers, and based on these functions, their structures are different. So next slide. Okay, we'll see what vessels each of the atria has. So first, the right atrium, it has the superior vena cava, it has inferior vena cava, and it has a coronary sinus. Now, the superior vena cava, it drains blood from all of the structures above the diaphragm. And the inferior vena cava, it drains blood, venous blood from all the structures below the diaphragm. So keep in mind superior, inferior. And then coronary sinus is like it drains blood from the myocardium of the heart itself into the right atrium. Now keep in mind all these vessels, they drain into the right atrium and they have deoxygenated blood. Then the left atrium, 4 pulmonary veins drain into that and they contain oxygenated blood and they come from the lungs. Now usually we see that veins have deoxygenated blood and arteries have oxygenated blood. Here it's the opposite. It's like in the fetal circulation. It's kind of like that. So next. Thank you. So here's another question. Which of the following is considered a feature in the right atrium? Yes, thank you. It is pectinate muscles. Okay, so trabeculae carneae is located in the ventricles. Chordae tendineae is located in the ventricles, and papillary muscles are also located in the ventricles. Next, please. Okay, so here this looks a bit chaotic, but so we'll start off with the atria. Okay, so from the outside, the atria have small little ear-like structures, and they're called the auricles. Auricles means little ears. Okay, and then from the inside, the posterior wall of the atria, it's smooth. But the anterior wall of the atria, it has these pectinate muscles. So pectinate means comb. So they're like comb teeth, you know. So posterior anterior surfaces are separated by this C-shaped structure. It's called the crista terminalis, okay? And then in the interatrial septum, there is this little shallow depression, okay? It's called the fossa ovalis. And this fossa ovalis, it comes from the structure in the fetal heart. It's called the foramen ovale, okay? And then we'll see the ventricles. If you can see the green part, like this little green highlighting thingy, it's like, you can see it's like irregular ridges. So it's called trabeculae carnae, which means that it's crossbars of flesh, okay? So they're more irregular. And then we can see papillary muscles are attached to the wall of the ventricle, and they attach to the chordae tendineae. Now, the chordae tendineae, you can think of them as heartstrings or like collagen strings, okay? And they attach to the cusps of the valves. The next, please. Okay, so this is a bit, I'm not like the best drawer. So here we can say that you can see like this person is standing on a table and he's holding up the ceiling. Okay, so you can imagine his legs as the papillary muscles, and you can imagine his hands like holding up the broken ceiling as the chordae tendineae. And the broken ceiling, obviously the valves are not broken ceilings, but this is just an analogy. So the broken ceiling, you can imagine it as the cusps of the valves. So this is to simplify it a bit. Next. Is it lagging? Oh, okay, sorry. Okay, so we talked about in the first question the differences between the ventricles. Now keep in mind that the left ventricle, it pumps blood to the entire body, so it's systemic circulation, while the right ventricle, it pumps blood only to the lungs. So there is a very huge difference in pressure here, although they will have equal volumes, but their pressure will be different. So to overcome like this little pressure difference, what happens is that the left ventricle has a very thick myocardium. It has a thick wall, and this gives it like a round shape, while and then it pushes into the right ventricle, so it wraps around it. So the right ventricle, it forms this like crescentic shape, while the left ventricle, it forms like this round fist-like shape. Okay, so how many openings can be seen to the cavity of the left atrium? Okay, yes, you're right. It's 4. No, it's not 1. Okay, we'll discuss. We'll discuss. Okay, 4Y. It says to the cavity, meaning it's like opening into the cavity. So that's you can see 4 pulmonary veins. They open into the cavity of the left atrium. Okay, another question is that which of the following is correct regarding the function of chordae tendineae and papillary muscles? E, okay. B, okay. Any other? Okay. Okay, so let's discuss. Okay, the correct answer is B. Why is it B and not C? So C says without them, the cusp would be blown downwards into the ventricles. Now, one word here is correct. For the previous question, yes, it is, but it says opening to the atria, not from the atria to the ventricles. Do you get it? That's why it's 4 openings, not 5. Okay, thank you. Next, Malak. Where was it? Yeah. So the question. So the inverted part of part C is correct, but the cusp won't be blown downwards. They will be blown upwards. Like without them, they will be blown upwards. We're trying to prevent backflow of blood, right? So the valves, they will be blown upwards if there is backflow of blood, like without the papillary muscles. So option B is correct, that papillary muscles do contract with other ventricular musculature. What that means is that when ventricles contract, the papillary muscles will contract as well to like shut the valves and prevent backflow of blood. I hope that's clear. If there's any question, do let me know. Okay, now I have like a little mnemonic. I don't know if it's going to be useful, but it says try before you buy. So we start from the right side of the ventricle, and it says it's try, so tricuspid before you buy. So bicuspid is on the left. So there are two types of valves that are found in the heart. Wait, before that, what is the function of the valves? They prevent backflow of blood. So there are two types of valves found in the heart, the AV valves and the semilunar valves. Now the AV valves are between the atria and the ventricles, and there are two types, tricuspid and bicuspid. Now as the name suggests, tricuspid has three cusps, bicuspid has two cusps. Now in the semilunar side, we have the aortic valves and the pulmonary valves. So yeah, that's it. Okay, another question. The atrioventricular valves open when the pressure in the... When do the valves open, basically? Mm, the AV valves. No. Is that all for answers? Okay, so the correct answer is D. Okay, so here we can do one thing. Since it's AV valves, the pressure in the arteries over here, it doesn't really matter. So we will cross out all the answers with arteries in them. So we will cross A and C, like automatically. Then we see why valves open in the first place. So valves are between atria and ventricles. So when we want the flow of blood downwards, what's going to happen is that when the pressure of the atria... Oh, it's okay. So when the pressure of the atria is greater than the pressure of the ventricles, blood flows downwards and the valves open. So that's why it's D. Okay, here's just the mechanism of why the valves open in the first place. So as I explained before, when the pressure in the atria is greater than the pressure in the ventricles, the AV valves will open. And then when will they close? When the pressure in the ventricles is greater than the pressure in the atria to prevent backflow. Okay, next. So this one is about the semilunar. Now here, the pressure in the artery is relevant, and it's... So basically, when the pressure in the ventricles is greater than the pressure in the arteries, what's going to happen is that the valves are going to open, okay, to push blood out. Now, when the ventricles relax and their pressure falls, what's going to happen is that the blood will start... The blood always moves from a place of high pressure to a place of low pressure. So now when the ventricles has low pressure, the arteries have high pressure, the blood is going to try to move towards the ventricles, right? So that's where the valves close. So next. Okay, now we're gonna talk about what happens if the if the valves don't close properly. So what would happen if the valves don't close properly? The blood will leak backwards. And this kind of valve is called an incompetent valve. It just can't do its job properly. So what's going to happen is that the heart will pump the same blood over and over and over again. And here I've attached another weird drawing. And it's basically, you can imagine it like a door that has a broken latch. So it just swings forwards and backwards. It's leaky. So what would this kind of valve sound like? So what would happen is that when the valve doesn't close properly, blood will go backwards. And this kind of sound, you can imagine it kind of like a swishing sound, right? And this kind of process, it's called regurgitation. Okay. So, so there's regurgitation when the valve is incompetent. Next, please. So there's another kind of valve, and it's what if the valve doesn't open properly? Like that's the opposite problem, right? So you can imagine it as like a door that's jammed, and there's a crowd of people like waiting outside, and they want to get in, and there's like the crowd just keeps getting bigger, but less people go inside the door. Or you can imagine it as like when you're drinking coffee, and but at the same time you're biting down on the straw and trying to suck in fluid. So you can't really have the coffee, you know, the coffee's not getting in because you're stopping it with your teeth. So that's exactly what a stenotic valve is. And why is it stenotic? Because it has some calcium salt deposits. Okay, so the heart has to work much harder because the opening is now very narrow. And what would happen is that the heart has to work much harder to pump the same blood. So a stenotic valve, okay, it will have like a sound, which is a high-pitched click sound. Okay, this sound is detected when the valve is supposed to be open, but it's not. So next, please. Okay, question time. A 6-month-old infant has pulmonary valve stenosis. Which of the following is expected in this patient? Mm, pulmonary valve stenosis. So pulmonary valve is where? Which side? Yes, exactly. It's A. It's A because pulmonary valve, first, like keep clarify this point for yourself that it's pulmonary valve, so that's on the right side, right ventricle. So there will be increased thickness of the right ventricle. Why? Because the heart has to work much more to to pump the blood. So next, please. Okay, another question. A 74-year-old woman with a history of rheumatic fever while in her 20s presents to her physician with complaints of shortness of breath upon exertion. She also has noted that a typical swelling she's had in her ankles for years. It started to get worse, and then on physical examination, the heart revealed a low pitch sound. What is causing this murmur? Any answers? See. Okay, it's actually B. Because we said in stenotic valve there is a high pitch sound, so we can just immediately eliminate that. And a low pitch sound, this could have been the swishing sound, and that usually happens in incompetent valves. So next, please. Okay, another question. What is correct regarding the what is correct concerning systemic circulation? Can't it be both B and C? Okay, Malak, can you go back to the previous question? See, murmur is usually due to the no, it's not. It cannot be C because SA node has nothing to do with murmur. Like in this case, because we're talking about valves, you know. So if valves don't open properly or close properly, that's where the pitch sounds come from. It comes from the valves itself, not the SA node. I hope that's clear. Okay, Malak, next. Yes. So can anyone answer this question? It's D. Okay, who said it's C? C says oxygen-rich blood returns from the lungs to the heart through pulmonary arteries. See, that's where I said it's pulmonary veins in this case. Pulmonary veins will carry oxygenated blood. Okay, so don't get confused between arteries and veins. Um, always read the question and the answer twice. Okay, so the correct answer is D actually. So it is oxygen-poor blood will return from the body to the heart through the vena cava, and A, oxygen poor blood leaves the heart and goes to the lungs through pulmonary veins. See, that's the same kind of confusion. Blood leaves the heart, deoxygenated blood leaves the heart through pulmonary arteries, not pulmonary veins. Okay? So next, please. Okay, here's just the path of the blood through the heart. So basically, we can just start with, okay, so when blood returns to the heart in superior vena cava, inferior vena cava, and coronary sinus, what happens is that it fills the right atrium, it goes through the tricuspid valve, it goes into the right ventricle, then it passes the pulmonary semilunar valve, and it goes into the lungs. Okay, so this blood we're talking about is the deoxygenated blood. Okay, it goes to the lungs from the right side. Then when it goes to the lungs oxygenated everything, and then it goes through pulmonary veins into the heart, the left atrium. So when it goes to the left atrium, it goes through the bicuspid valve into the left ventricle, and then it goes through the aortic valve to the whole body. So it's pumped to the whole body. That is basically like the full cycle. So next, please. Okay.
Okay, we're done with the anatomy part. We are supposed to have a break for Dhuhr. So we can't just have a 10-minute break from now because Dhuhr is in 10 minutes. We could do a quick run through of the conduction system, the first part of conduction system, and the moment that it's Dhuhr, we can have the break and then come back after 15 minutes. Is that okay with everyone? And also, Zarlala, you have a question in the chat.
Okay, give me a second. Question regarding pulmonary arteries for deoxygenated blood, but veins for oxygenated blood. What do you mean? Wait. Pulmonary arteries. Okay. Pulmonary arteries, okay, they carry, I'm confusing myself. Okay, they carry deoxygenated blood. And pulmonary veins, they come to the left atrium. Okay, when they're coming to the left atrium, they come from the lungs, right? So the lungs, they have a lot of oxygen. So this blood is going to be oxygenated. And second thing is that the left side of the heart, it's a systemic pump. It will pump blood to the entire body, right? And do we want the body to have oxygenated blood or deoxygenated blood? We want them to have oxygenated blood. So you can like remember that. Also, I said in this case, the roles of the veins and the arteries are kind of reversed. Like, yes, the arteries do leave the heart, but they will leave the heart with deoxygenated blood. And the veins will come to the heart with oxygenated blood. So I hope that clarifies. There's any other question, please do let me know.
Okay, so we'll have a quick run through of conduction system, just setting the basic rhythm. So the intrinsic conduction system. Okay. Before we start, there is a question. So which of the following is correct regarding the intrinsic conduction of the heart? We have Purkinje fibers cross impulses from atria to ventricles, start at pacemaker at the apex of the heart, or composed of special tissue found in the heart and skeletal muscle tissue, or much like a cross between muscle and nervous tissue. Let's go through all the options. So Purkinje fibers cross the impulse from atria to ventricles. This is exactly what they don't do. So Purkinje fibers are in the ventricles and they carry the impulses so that the ventricles can contract, right? They're not in the atria. Then we have the start at the pacemaker at the apex of the heart. The pacemaker is not at the apex of the heart. We'll see that later. They are in the right atrium. And then it's composed of special tissue found in the heart and skeletal muscle. Here, the keyword is skeletal muscle, which makes this entire option wrong because skeletal muscles don't have intrinsic conduction. They are supplied by the nervous system. It is much like a cross between muscle and nervous tissue. That is the correct answer because we have our contractile cells and then we have our special pacemaker cells. Now, another question. Which of the following indicates the conduction system of the heart is and its proper location? So we have AV node in the right atrium, Purkinje fiber within the muscle of the atrial walls, SA node in the intraatrial septum or bundle of His in the interventricular septum. Okay, that one is straightforward. So AV node is not in the right atrium. It's we'll see later where it is. The Purkinje fibers are in the ventricle walls, not the atria. I already said that. And SA node, again, we'll see where it is. So they're actually flipped, the SA node and the AV node. Let's go through the components very fast. We have the SA node, your pacemaker, then the AV node, and then your bundle of His, or the AV bundle, and it's the only connection between your atria and ventricles, okay? There is no other electrical conductivity going on in the heart. Then you have your bundled branches left and right, and your Purkinje fibers going through the ventricular walls, or they're also called the subendocardial conducting network. For locations, it's a quick summary of where they are located, but in simple terms, SA node, right atrium, don't confuse it with the interatrial septum, which is where the AV node is. So don't mix these two, because clearly the question mixed them and you can get confused. Then the bundle of His in the interventricular septum, and the left and right bundle branches. And then you have the myocardium of both ventricles with the Purkinje fibers. Lastly, the speed of conduction, just very quickly, we know that the SA node is the pacemaker of the heart, the main pacemaker, because all of the cells that can conduct are called pacemaker cells of the heart. But the pacemaker, the main one that ultimately decides how fast your heart beats, is your SA node with 75 beats per minute. If anything happens to it, others can take charge, but in normal cases, it's your 75 beats per minute for the SA node. One more question. So we have 50-year-old patient reporting with bradycardia. ECG reveals inverted P waves, suggesting a non-functional SA node. Given that we have options and which of the following is the normal order that the impulses pass across the heart. Now, this question is there to confuse you. Again, there is a clinical scenario that has nothing to do with the main question. They're giving you a clinical scenario to confuse you. You might say, okay, so he has a defective SA node. That means I'm going to not consider that the SA node is the first thing that beats. And that's completely wrong. So the problem here, you need to identify what is the question asking from you and read it properly. Here I underlined normal so that you can look at it and see. So the correct answer should be D. Everything else is completely wrong. If it starts with AV node, then it's wrong. It has to start with SA node. Okay. The sequence of excitation, we just discussed it. So the first thing in normal cases is going to be the SA node. If it's defective, then the AV can take over. But normal cases, SA node. Okay, now when you're going from your SA node to your AV node, right, there's a delay where the atria contract, and then there's a 0.2 delay, and then your ventricles contract. Now, subhanAllah, this is happening because of something. We'll see it later. When you have your traffic, you have cars on the road, you have 5 lanes merging into like 2. Okay, you'll start to see there's a lot of traffic. So this happens at the AV node as well. You have a smaller diameter of the fibers and you have fewer gap junctions. Now, the impulses are passing through from the SA node to the AV node with those gap junctions. One more question, and I think we'll pause at here before we go into the action potentials and the pacemaker potentials. So which of the following is a characteristic of the SA node action potential? This one's very easy if you've already went through the chapter. Okay, so plateau is not from the SA node. Repolarization is for every single thing that depolarizes, it has to repolarize, right? Pacemaker potential is the right answer, and depolarization happens in, again, anything that is repolarizing, it has to depolarize first. Right, so it is C, pacemaker potential, goes for the SA node, or any cell in the heart that is a pacemaker cell. Again, don't confuse the two. The SA node is the main pacemaker of the heart, but any cell that can conduct in the heart is a pacemaker cell. Okay. Quick recap of where we left off. We discussed the conduction system, the intrinsic conduction system, the components, SA node, AV node, bundle branches, all of that. And we also talk about the sequence of excitation, why there's a delay, and then we are at the part where there's action potentials. So in your textbook, there's this lovely question, which has the skeletal muscles, the contractile cells, and the pacemaker cells action potentials in a question, and they're asking you which one's which. if you guys can write in the chat what you think which is which, or I'll just go ahead and spoil it for you. So the skeletal muscles one is very distinct. It's a simple depolarization, repolarization, and you're done. If you can also have hyperpolarization like you learned in the muscle chapter, but the simplest one is just you depolarize, you repolarize again. The cardiac muscles, very distinct. They have a very long plateau for sustained contraction. And the pacemakers have, again, a very distinct pacemaker potential. And we'll see that when we're talking about the pacemaker potentials versus the action potentials of cardiac muscle cells. Okay, so this again is a comparison between the two. And if we go into more details, if you guys want to answer the question asks, which of the following events is mainly responsible for the action potential in the cardiac non-contractile cells? So when we're talking non-contractile cells, we're talking pacemaker cells of the heart, the ones that are doing intrinsic conduction, right? So in normal muscles, we have the influx of sodium that causes the depolarization. Okay, yes. It is influx of calcium ions. So when you have pacemaker potential, when you want to depolarize, after that, you do calcium. We'll look at how that happens. So quick review. Again, we have the pacemaker potential. The first thing that happens, we just want slow. We want everything to be slow. We don't want a quick depolarization, right? So we're going to open slow sodium channels. The sodium will slowly leak in, right? Will depolarize the membrane a bit, but it will only make it reach threshold. We're not going full action potential yet, right? So this is the pacemaker potential. We're taking it enough to reach threshold, but we're not doing an action potential. Okay, the moment we reach here, all right, the calcium channel is open. There's an explosive, like your textbook describes it as an explosive rise, like influx of calcium, all right? The calcium will go in and depolarize the membrane. You will get your depolarization phase. Okay, after the calcium bit is over, we need to repolarize again. Repolarization is the same for almost everything. You have the opening of potassium and the closing of whatever was helping us depolarize. So in this case, it's calcium. We're closing calcium, we're opening potassium, and we're allowing the membrane to repolarize again. That should be simple. So we have another question. Which of the following is the consequence of the plateau phase in the action potential of contractile muscle cells? So we haven't covered that yet, but let's see if you have any idea about it. So the options are to ensure sustained contraction, to restore intracellular calcium ions, or to provide the 1 second delay, or to allow the tetanic contraction. Okay, so for the first one, that's clearly the correct answer because I just said, yeah, no, it's not B. Okay, restoring intracellular calcium doesn't happen in the plateau phase, right? It will happen after like everything is done, right? In repolarization. After, like in repolarization, this is when khalas, we don't need the calcium anymore. We're closing the channels. We're removing all the calcium because we don't want the membrane to be polarized. Okay. Then we have the 1 second delay. The 1 second, the 1 second delay was not done by any of this. It was done by the AV node, right? Because less fibers, less smaller fibers and less gap junctions. Then to allow the tetanic contraction, that's very wrong because in the heart we don't have tetanic contraction, right? We're having this delay to avoid it. Okay. So again, quick overview of our action potentials in cardiac muscle cells. What you really need to keep in mind here is that what's happening in depolarization is not calcium compared to the other one. Depolarization was calcium, right? Here, it's not calcium, it's actually sodium again. So fast sodium rushing into the membrane, depolarization happens, okay? After that, this is the slow phase where we need a plateau to have sustained contraction, okay? And after all of that happens, again, we have repolarization. So it's the same in everything. Potassium will open, calcium will close, or whatever was helping us maintain the depolarization will close. Okay, one more question. Because of the distribution of the cardiac impulses by the conduction system, ventricular contraction begins where? At the semilunar valves, or at the superior part of the ventricles, or the apex, or the papillary muscles? So this is a very easy to confuse question because when you're learning the conduction system, you're seeing that the SA node is starting from the atria, right? So you're like, oh, the conduction is happening from the top to the bottom. So of course the contraction will happen the same way. But I want you to not confuse these. So the conduction will happen at the apex of the heart, and we want the blood to be pushed upwards and out of the heart, right? So don't confuse conduction with contraction. Conduction will happen from the SA node down, and then the ventricular contraction will happen from the apex up so that the blood is pushed out of the heart. That should be it for intrinsic control. This is a question for extrinsic control, and it's a huge paragraph, but I'm very sure that I overworded it so that it looks complicated, but the question is pretty simple. So all it's asking you is, all of these words summarized, they're asking you what is the extrinsic control, like what is the source? Where is it coming from? Is it the basal nuclei? Is it the cerebral cortex, the medulla oblongata, or the thalamus? It is the medulla oblongata. Okay. So when you're thinking extrinsic control of the heart, always think medulla oblongata. Whatever comes from it, we'll see now. The cardio-acceleratory center or the cardio-inhibitory. As the name suggests, if it's cardio-acceleratory, you're making the heart go faster. If it's cardio-inhibitory, you're making the heart go slower. Okay? Now, when there is an issue happening, when there's like a fire alarm, you need to notify everyone. Everyone needs to be notified, okay? You're on alert. Everyone needs to go to the emergency exits. Everyone needs to gather in one place. So everything needs to be notified. The SA node, the AV node, the heart muscle, the coronary arteries, everything. You need to notify everyone in the heart that there's an issue. But if you're in parasympathetic, if you're rest and digest, you've just had your iftar, okay, you're watching your shows, you're very relaxed. You don't need to notify everyone that you're relaxing, right? So you'll just tell the SA node, the AV nodes, okay, we're relaxed. The heart will beat slower. That's it. That's all you need to know from here. This is a summary table as well if you want to go through it after. And with that, the conduction system is done. The electrocardiography is very important. It's very easy to memorize, but if you like mess up something, it's like, why did you do that, you know? Like it's a very simple concept if you think about it. It's just a couple waves. You need to know what each wave does, or like what's happening when each wave happens, and you're good to go. Okay, moving on, we have the electrocardiogram. So as I was saying, this is very important that you guys just know exactly what each wave corresponds to, and you're good to go with ECG. So first question, which of the following components of the ECG is not correctly matched to the corresponding event occurring in the heart? So P wave, atrial depolarization, T wave, atrial repolarization, PR interval to AV node conduction, or QRS complex ventricular depolarization. Okay, yeah, that is correct. So please, when you're reading questions, even if you know that you've read the question, read it again, because sometimes you can miss this knot and you can look at the first option and you're like, okay, this is correct, I'm gonna pick it, and there goes your mark. But you knew the answer, just be careful of that. So electrocardiogram, very simple. If you want a more simple way to remember it, anything on the left side, which you know when you see the anatomical representation of the heart, the left is on the right and the right is on the left. So not your directions, but the anatomical directions. So anything on the left is atria, anything on the right is ventricles, or in heart anatomy, anything on the right is atria and anything on the left is ventricles, right? So smaller wave is a smaller chamber. P wave is small, so it's for the atria. The bigger waves, the more like the ones that scream, I'm here, right? Those are your ventricles. This is related to your ventricular depolarization. This is your ventricular repolarization, okay? Everything in between is corresponding to events that happen in between. So your PR interval will be related to your everything, like atria depolarizing, and then a bit of repolarization, but you really don't see repolarization of the atria in the ECG, right? And then your ST will be related to whatever's happening in your ventricles. So this is a plateau. This is the sustained contraction. And one thing to note about your electrocardiogram that is different about your when you look at your AP graphs, your action potential graphs, what is the difference between this and whatever we're looking at when we're looking at action potentials? We're measuring electricity at the end of the day, right? So the ECG combines all electrical activity of the heart. It doesn't matter if it's like one location or the other. In your graphs where you're looking at action potentials, you're looking at one chamber, or you're looking at like what's going on at one location. Here, you're combining everything together. Okay, one more question. A 52-year-old male patient suffered from chest pain and was brought to the E&E. His ECG was normal except for elevated ST segment. Which of the following is the most appropriate diagnosis? So keyword here is elevated ST segment, and this is in the list of diseases that's with your ECG, your abnormal ECGs, and it's very easy to miss this list of 3 diseases that they've put because it's a small box at the end of the section, right? So you have cardiac ischemia or atrial fibrillation or junctional rhythm or sinus bradycardia. This is purely memorization. No, it's cardiac ischemia. I will try to explain them to you guys. They're not really explained in the textbook when they mentioned it, but I will try to explain them so you can memorize them even more. So an enlarged R wave, or actually what they mean by enlarged is not widening, it's higher. It's a longer R wave. That means you have enlarged ventricles. It's easy to remember if you associate enlarged with enlarged, but also you can know the reasoning behind it. So when you have larger ventricles, like more muscle, more you have more area, right? You will have more conducting cells as well with your muscle. And that means you will have a greater electrical potential. And when that happens, your R wave will be higher. That's because you will have higher potential. So put 2 and 2 together. Then the elevated or depressed ST segment, meaning you have cardiac ischemia. What happens when you have ischemia? You cannot have a maintained gradient. Your cells are not working the way they should be. You can't control the ions. So you will have the altered resting potential. When you have altered resting potential, right, you can have fluctuations with how your ST segment looks because, again, the ECG is combining everything that's happening in your heart. So it's like a mean or an average. If a part of it is a bit lower, right, the average will be a bit lower. If it's higher, then your ST segment will be a bit higher. Okay. Prolonged QT interval means that you have repolarization of abnormality. So what is your QT interval usually meaning? It's signifying that your ventricles are depolarizing and then repolarizing, right? So if you have any issue with your repolarization, if it's longer, if it's shorter, then you will have prolonged QT intervals. Okay, that's it for these 3 diseases. Now, one last question so that we can look at the abnormal ECGs. We have medical student examining the ECG tracing of a patient in the emergency room. And he realizes that there are more P waves than QRS complex. Which of the following is the best diagnosis for this patient? Okay, awesome. So this is actually, again, also purely memorization. You memorize how your diseases look like on the ECG and how they correlate with the symptoms. So I just the most important part that I don't want you to confuse are junctional rhythm and second degree heart block because they're both involving the P waves, but in one of them, your P waves are missing. The other one, your P waves are more than usual, right? So in junctional rhythm, your SA node is not working. If your SA node is not working, your atria are not depolarizing. If the atria are not depolarizing, the P wave that represents atrial depolarization will not be there. So you will have junctional rhythm. Why is it junctional rhythm? Because your AV node is at the junction, right? Then you have second degree heart block. This is where the AV node fails, but the SA node is working. So the SA node will continue to give impulses to the atria. The atria contract, but the AV node is not getting the signal. So it gets it sometimes. So you will have QRS complexes, but you will not have them as often as you have P waves. You can have double P waves. And the most easy one is ventricular fibrillation, where it looks like squiggles. There's abnormality, and I think we all know the solution to this is usually electric shock. So you basically reset the rhythm of the heart. And that's all for electrocardiogram. There is one question to take us over. Okay, this is to sum up everything for ECG. So a 40-year-old male presents to the clinic with severe retrosternal crushing chest pain accompanied by sweating and nausea. Examination and investigation revealed that the patient has an acute myocardial infarction. Which of the following is the common complication that could be happening in the patient if he is not treated? Again, this is the clinical scenario, and I didn't underline the keywords here, so I'll see if you can identify them. But it's, again, a bunch of words, and you really need to figure out what they're trying to ask from you here. It's a bit difficult because it combines this and it combines another concept that we took with the coronary vessels. So what's the problem here? He has retrosternal crushing pain. We also saw this pain when we were talking about coronary blockage, right? He has a myocardial infarction, so he has death of heart cells. This is again because he doesn't have oxygen going to his cells. That usually means he has a blockage of the coronary arteries. So which of the following would be the most common complication that happens is a ventricular arrhythmia. It's because blood is not going to his ventricular walls. If he's not getting blood to the ventricular walls, he's ischemic, like the tissue is ischemic, it will not conduct. And if it's not conducting, it cannot contract. Okay? No contraction, ventricular arrhythmia. Or not no contraction, sorry, irregular contraction, because not all cells will be non-conducting. Some of them will conduct, so they will conduct irregularly. This question, again, a whole paragraph for nothing. It's the last question just asks you which term best describes the event of one complete heartbeat, including the atrial and ventricular contraction following by relaxation. And this question was just to take us from this section to the cardiac cycle. So the correct answer here is cardiac cycle. Okay. What are we looking for in the cardiac cycle? Let's first have a question. Is there a question? No, there is no question. Okay, let's see what we're looking for in the cardiac cycle. When you see this diagram in your textbook, you might be intimidated, but it's actually like the most perfect summary you could ever ask for the cardiac cycle. It sums up like everything related to the pressures, the sounds, the ECG. So if you're going into the exam and you need to revise one last thing before entering, this should be it. It combines everything so perfectly that I don't think you'll be missing out anything related to the cardiac cycle. Now, when we're looking at the cardiac cycle, I need you to keep in mind some key rules, okay? And if you understand these key rules, everything else is like a walk in the park, okay? So the first thing is that blood will flow from high to low pressure, a pressure gradient, right? If you have a pressure gradient, your blood will flow. Now, if you have this pressure gradient but your door is closed, you can't pass through. You need to open the door. So valves need to be open. Common sense, right? The third one is that when you see lines crossing on your graph, it means either a valve was open or a valve was closed. Okay? And then if you have a pressure difference, ultimately you will have the valves opening or closing. So putting point number 1, 2, and 3 together, you will get if you have a pressure difference, you can open or close valves. If you see the word isovolumetric, that either means there is increase or decrease in the pressure, but your blood volume inside the ventricles or inside the chamber is the same. It's not changing. And then the last part is the electrical events precede the contraction. So you need to have the signal and then you will have the action. So signal is your electrical events and then you'll have the contraction of the heart or the chambers. Okay. Matching question. You have isovolumetric contraction, volemic contraction, relaxation, or ventricular systole or ventricular diastole. Which ones go where? Okay. We can actually go through the question, the sequence first before we go answer this. Let's look at them. So I want you, when you're thinking about each phase of the cardiac cycle, to think about 5 things, okay? What is the pressure in the chambers? What is the mode of blood flow? Is it passive? Is it just flowing? Or is there contraction of the chamber? The third point is you need to state, like, what are the valves? What's the state of the valves? Is it open? Are they closed? Is the AV node of the AV valves open, or are the SL valves open? Which ones are open, which ones are closed? Okay, ECG findings, correlate them. Correlate which ACG phase are we in right now. And of course, the final blood volume. Okay, once you know all these 5 points, you'll be able to answer any questions related to the cardiac cycle. Because when there are questions about the cardiac cycle, you will notice that they're linking together things from all over the place, the ECG, the valves, the blood flow, okay? So you need to consider everything when you're talking about the cardiac cycle. This is why, by the way, the diagram in your textbook is perfect. It correlates everything together. So let's talk about ventricular filling. What's happening to the pressure? Everything's relaxed, right? We're starting in mid-diastole, everything's kind of relaxed. The blood is flowing through the AV valves, right? So that means what? It means the AV valves are open. And we don't want blood to flow through the aorta and the pulmonary vessels yet, right? So we are closing those valves. We're closing the SL valves. For mode of blood flow, at the beginning in mid-diastole, we're relaxed. Nothing is happening, no contraction, everything's fine, okay? But at the end, when khalas, like there's a little bit of blood left, we're gonna contract the atria a bit just to get enough blood, like to get everything into the ventricles, okay? For ECG, this part is basically like before the P wave, and then the P wave depolarizes the atria, right? After the atria depolarize, they will contract. So we're basically finishing the P wave, and then we're starting a bit of the QRS complex, but the ventricles are not contracting yet. This is before ventricles start to contract. The blood volume at the end is your 120 per ventricle, and this is called your end diastolic volume. Why is it end diastolic? Because this is the last bit of the diastole. This is khalas, we're relaxed, and this is your end diastolic volume. Moving on to your isovolemic contraction, where you have your ventricles are contracting. Again, so iso, same volume, okay? But your pressure is increasing. So technically, the ventricles are contracting, but nothing is happening to the blood volume. The valves are all closed. So your ventricles are right now closed chambers. Nothing is happening to them, but they're contracting. The state of valves, all closed. In this part, the ECG, the ventricles are depolarizing, right? Because they need to contract. Electrical events before contractile events. So QRS complex happened. The final blood volume is the same. It's still 120 milliliters. And then you move on to your ventricular ejection. As the name suggests, you're removing the blood out of the ventricles. So the pressure in the ventricles exceeded that of the blood vessels. And when that happens, your semilunar valves open, okay? And your final blood volume here will be 50 milliliters. Those 50 milliliters are your remaining, and then 70 are pumped out. So 70 is the stroke volume, and you will see this later with Zarlala when she talks about your cardiac output. Okay. And for early diastole or your isovolumetric relaxation, so the last bit, okay, when you've emptied your ventricles are relaxing. But again, the volume is the same. So nothing is happening to the 50 milliliters of blood, and this is called your end systolic volume. Why is it end systolic? Because you just ejected blood out, you've done your systole, and after that you're remaining with 50 milliliters of blood. That's your end systolic volume. Okay. So there is a question here, but I told you that we'll do the matching questions before that there. You guys can try the first one on your own later. It's actually simpler than this one. So match the following cardiac cycle events with the correct events or features. You have ventricular diastole, isovolumetric contraction, or isovolumetric relaxation, and then your ventricular systole. So we always have a constant volume of blood in our chambers. Whatever is in one ventricle will match the other ventricle. If you have 120 in one ventricle, it should be 120 on the other side. And if you pump out 50, right, if you pump out 70, sorry, you will have 50 remaining in both ventricles. Is that what you meant? You don't always have a constant volume, right? Because you're pumping out and getting blood again. But usually in a healthy person, the average is around 120 milliliters per ventricle. So that answers your question. Oh, you mean, yeah, those 50 are not pumped out. That's your end systolic volume. It doesn't get pumped out. Okay. So the answer for this question is, okay, your P wave and then your AV valve closes and then your aortic valve. Okay, so ventricular diastole will match with the, okay, yeah, you got it right. Okay, no, wait, no, you didn't get it right. It's D, not B. What is B? T wave. T wave has nothing to do with the atria, right? Am I on the... Okay, no. Ventricular diastole. So oh yeah, this is at the beginning. Yes, this is the P wave. So you have the P wave, your atria contract a bit to let the blood out through, and then you have your AV valve closes when you have isovolemic contraction, because in isovolemic contraction, everything is closed. Isovolemic relaxation, everything is closed. So AV valve closes. The aortic valve closes, yeah, in 3, and then the stroke volume is ejected in ventricular systole. The ventricles contract. It's not T wave. T wave happens when your ventricles are relaxing. Or no, repolarizing, and then they relax later after the T wave. Because electrical events before your contractile events. Does that make sense? Okay. This is a very quick summary table. Again, if you just need to review it before your exam, combines all the phases of your cardiac cycle. And then one more question about cardiac cycle, but this one is related to the sounds because we're moving on to sounds after this. So the second heart sound is heard during which phase of the cardiac cycle? Okay. So second sound in isovolumetric. A trick to remember sounds is that they will be happening in your isovolumetric phases. So your first sound is when your AV valves close. Do you remember in the isovolumetric contraction? It's a closed system. So when that happens, right, the valves shut. And when they shut, they make a sound. So the first sound you hear is the AV valves because of the isovolumetric contraction. And then the second sound during isovolumetric relaxation, when the blood is pumped out through the vessels, the blood kind of falls back a bit because of gravity, right? And it lands on the SL valves, making a sound again. So when these shut, when the SL valves shut, you also get the second sound. What was the difference? The first one is louder and longer, and the second one is a bit shorter, and the sound is sharper. So the first one is resonant, and this one is sharp. For locations, again, purely memorization, you have 4 locations that kind of make a square if you remember it. You have 2 on the left and 2 on the right. And they're almost at the same level. So if you remember second intercostal space and second intercostal space right and left, okay, and then you remember your fifth intercostal space right and left, and the most distinct one is your mitral valve because it's over the apex. And again, one last point to note, I don't remember if there was a question about it, but wherever you hear your valve sounds is not where the actual valves are located. It's very clear in this diagram. And that's all for cardiac cycle and for my whole part. The last bit is heart physiology by Zarlala, and inshallah we'll be done with the whole chapter.
Okay, thank you, Malak. Hello, guys. We're going to be talking about heart physiology. We will learn about stroke volume, heart rate, cardiac output, and how each of them are different. So next, please. Okay, so we have to know, you guys have to know the formula of cardiac output, which is heart rate times stroke volume. So what is heart rate? Heart rate is the number of times the heart beats per minute, okay? And the stroke volume is the amount of blood that leaves the ventricle with each beat, okay? So this makes the definition of the cardiac output as the amount of blood that leaves the heart per minute, or leaves the ventricle per minute. Okay, is that clear? So now we will move on to stroke volume and how that is calculated. So we have stroke volume is equal to the end diastolic volume minus the end systolic volume. So what is the end diastolic volume? End diastolic volume is basically the amount of blood that's in the ventricle during diastole, so while the ventricle is relaxed. And end systolic volume, I think you touched upon it with Malak. It's the volume of blood that remains in the ventricle after contraction. So the difference between them will basically give you the total amount of blood that actually left the heart per beat. Okay, so what affects stroke volume? So there are 3 things that affect stroke volume. The first one is preload, and preload is basically the muscle stretch before contraction. Then we have contractility, which is the strength of the contraction at a given muscle length. And then we have something called the afterload. Now, remember we said that the blood moves from an area of high pressure to an area of low pressure. So when the ventricles, they contract, their pressure is actually higher than the pressure in the arteries, right? So the afterload is basically that. It's the pressure that the ventricles have to overcome to eject blood. Now, preload and contractility, they're actually very significant in affecting the stroke volume. They affect stroke volume a lot, but then afterload, it's usually not that significant in people, like normal people, But in people that have hypertension, like as in high blood pressure, so they have very high blood pressure in their arteries. So the ventricles, they have to overcome a higher pressure. So the afterload is greater in people with hypertension. Next, please. Okay, we have a question. Which of the following statements best describes the Frank-Starling law of the heart? Does anyone know this? Any other answers? Should I explain? Okay. Um, A, D, no. Okay. The answer is actually B. Its cardiac muscle stretch is directly proportional to stroke volume. And we will look at the next, in the next slide, I will explain this. So let's go to the next slide, please. Okay, so the name's kind of fancy, but it's basically just this whole thing, okay? So basically, the venous return, meaning the amount of blood that returns to the heart when it's greater, there is a lot of the end diastolic volume, so the volume during diastole in the ventricles is greater, okay? And that's called preload. Preload is the degree of muscle stretch, right? So this relationship between the preload and the stroke volume, so the degree of muscle stretch, when there's more muscle stretch, the stroke volume will be greater. So more blood will be ejected out of the heart. Do you get that? And why is muscle stretch greater? Because there's more blood. So it's like, and then when stroke volume increases, obviously cardiac output also increases. So the Frank-Starling law is basically just this relationship between the preload or the degree of muscle stretch and the stroke volume. Someone asked if there's calculations. I think just mostly they will say like maybe if stroke volume decreases, what would happen to cardiac output and things like that. So they will test the relationship in the formula, not just calculations. Okay, next one, please. Okay, we have a question. Which of the following most directly increases venous return in a healthy adult? Venous return, as in the blood that returns back to the heart. Okay, so the answer is actually C. Now, why is it not D? Arteriolar vasodilation in skeletal muscles. Vasodilation, remember that vasoconstriction kind of pushes the blood upwards. Vasodilation would kind of slow the blood down. Do you get that? And there is this. The answer is C because increased activity of the skeletal muscle pump. So skeletal muscle pump, they would kind of press on the veins and pushing the blood upwards towards the heart. I hope that's clear. If there are any questions, do let me know. Go to the next one. Okay, this is just like a summary. So more venous return, more blood returns to the heart. Obviously, there will be more ventricular filling. When there is more filling, there will be more preload, and preload is muscle stretch. The muscle of the ventricle will be stretched more. Therefore, there will be stronger contraction. Stronger contraction, more blood will be pumped out, so stroke volume will be increased. And according to the formula, cardiac output equals the stroke volume times heart rate. So when stroke volume increases, cardiac output will increase as well. Next one, please. This picture was the muscle pump that I was talking about in the question before. Yeah, the one below, this one. It squeezes the blood. So, okay, let's move. Okay, this is a question about cardiac reserve. A 27-year-old endurance athlete and a 27-year-old sedentary man, or a normal man, they both have a resting cardiac output of 5 liters per minute, and during maximal exercise, they both reach the same maximum heart rate. So the athlete achieves a cardiac output of 30, while the normal man reaches only 18. So which of the following best explains this difference? Okay, so what does cardiac reserve mean? Cardiac reserve is basically the difference between the maximum cardiac output and the resting cardiac output. So the answer here is C. The athlete increases stroke volume more during exercise. Like the athlete has a greater stroke volume while he's exercising. That's why his cardiac output is more. Even though they have the same heart rate. Like, so if you look at the question, they have the same heart rate, but the cardiac output of the athlete is different. It's more. So what in the formula could be increased if heart rate is the same to give a greater cardiac output? It would be stroke volume. So next one, please. Okay, so this table is very, very important. Okay, so this shows like how what affects stroke volume, what affects heart rate, and overall how cardiac output will be increased. So first we said by exercising, we're increasing the skeletal muscle, the pumps of the skeletal muscles, they pump more and they increase the venous return towards the heart. So there's increased venous return. Second one is ventricular filling time due to decreased heart rate. So when the heart beats less frequently, there's more time for the blood to actually fill the heart, fill the ventricle during diastole, and this all increases venous return. Okay. Now, and then of course, when venous return is increased, the stretch of the muscle is more blood returns, more blood fills the ventricle, so end diastolic volume is greater, and therefore stroke volume is also greater. Then there are certain chemicals like epinephrine, thyroxine, and calcium ions. They will increase contractility, and we'll talk about them in a bit. And that will decrease the end systolic volume. Now, end systolic volume, we said, was the blood that remained in the heart after systole. So when end systolic volume decreases, stroke volume will also increase. Now, if there is, for example, changes in the autonomic nervous system, like for example, if you're experiencing anxiety or if you're scared, there will be an increase in the sympathetic activity and decrease in parasympathetic activity. And that in turn increases the heart rate and increases cardiac output as well. Now, increase in sympathetic activity also affects contractility. So let's move on. Okay, there's a question. A patient with hypertension is prescribed a beta 1 adrenergic blocker. Which of the following best describes its primary mechanism of action? Okay. Any other answers? Yes, it's B. Because actually we'll discuss that in the next few slides. But what is beta 1 adrenergic receptor? We beta 1 adrenergic receptor. Okay, we'll just do that in the next slide. I think the pictures will make it clearer. Yeah, here. So there is a receptor called the beta 1 adrenergic receptor, and molecules like epinephrine and non-epinephrine will act on it. And when they act on it, there will be a series of reactions that will happen. And basically, the whole point of this thing is to increase the amount of calcium released, right? So when there's a lot of calcium, calcium will bind to troponin, and there will be more number of cross bridges binding for contraction, and force of contraction will increase. So contractility it depends on the amount of calcium, right? So it's an intrinsic factor, and it does increase stroke volume. So if you see here, when there's increased contractility, stroke volume will be increased. So if you increase the force of contraction, more volume of blood will leave the heart, so less volume of blood will remain in the heart, and end systolic volume will decrease. So at the end, if we look at the formula of stroke volume equals to end diastolic volume minus end systolic volume. So if end systolic volume decreases, stroke volume will automatically increase. Do we need to know the mechanism? I think you need to know what beta 1 adrenergic is and what would happen if you block it, like the question before this. So yeah. So like what would happen if you block it and all that? And what's the point of this reaction? Like also you need to know what contractility depends on. So it depends on calcium ions. So let's go to the next one. Yeah, after this. Okay, so there are certain chemicals that will affect contractility, and there are two names for them. One is positive inotropic and one is negative inotropic. So positive inotropic, from the name, we can tell that it will increase contractility, and negative inotropic, they will decrease contractility. So you have to memorize this, especially in the positive inotropic, when we can see hormones like epinephrine, thyroxine, glucagon. We can see the drug digitalis, and there are a lot of questions about digitalis, and a high level of calcium. They're all positive inotropic agents. Then negative inotropic agents, things that will decrease the contractility of the heart. So that can be acidosis, so increased amount of hydrogen ions, increased amount of potassium levels extracellularly, and drugs called calcium channel blockers. Okay, so which of the following is considered a positive inotropic agent or a factor? Hmm. Okay, it is B. It's thyroxine. Yes. Okay. Next one, please. Okay, a 65-year-old man with chronic systolic heart failure presents with fatigue and shortness of breath on exertion. The cardiologist decides to start digitalis therapy. Which of the following is the primary cardiac effect of digitalis that contributes to improved cardiac output? So they're basically just asking you what digitalis does. Is it positive inotropic or is it negative inotropic? Yes, exactly. Any other answers? Okay, the correct answer is B. It will increase contractility because it's a positive inotropic agent. Okay, let's move on. Okay, so imagine that you have someone got into an accident and they're losing a lot of blood. Okay, now the whole we want cardiac output to be maintained, right? How will we do that? Now, if he's losing a lot of blood, that means that not a lot of blood will be returning back to the heart. Not a lot of blood will be pumped out. So stroke volume will automatically decrease, right? So in the formula of cardiac output, if stroke volume is decreased, how will be how will we increase the heart rate? Sorry. Oh my God, I got distracted. Wait. Okay. So stroke volume would decrease. So how would we increase the cardiac output? Okay, by increasing heart rate. Okay, and also by increasing contractility. And contractility is because when the sympathetic nervous system is activated, when you're losing a lot of blood, basically there's a lot of vasoconstriction. So when there's vasoconstriction, you're squeezing the blood. Okay, you're squeezing the blood towards the heart. So that also helps. So at the end of the day, the cardiac output will be maintained. So the next one, please. Okay. So we talked about sympathetic responses, and now let's talk about parasympathetic responses. So the entire goal of parasympathetic responses is to keep a lower heart rate, okay? And this is mediated by acetylcholine. Now, acetylcholine will cause the potassium channels to open, which causes potassium to leave. So the membrane is hyperpolarized. Okay, so in resting conditions, we can say that parasympathetic system is more dominant. So there's something called the vagus nerve, and there's in the book it mentions that what would happen if the vagus nerve is cut, since it's the dominant system. and it's the part of the parasympathetic system. What would happen if the vagus nerve is cut? Basically, what would happen is that you will experience a sudden increase in your heartbeat to like up to like 100. So it's important to remember that parasympathetic is the dominant one in this case in resting conditions. So let's go to the next one, please. Okay, a question. A 60-year-old woman receives a rapid intravenous infusion of 1 liter of saline. Her central venous pressure rises, her atrial walls stretch, and within seconds, her heart rate increases through an autonomic reflex. Now, which of the following explains the mechanisms underlying this? Any answers? Basically, they're asking, okay, that her venous pressure rises and her atrial walls stretch. Now, they're asking about the relationship between atrial wall stretching and her heart rate. The answer is no one can answer. Okay, thank you. It is A, yes. So stretch of atrial walls will activate atrial stretch receptors. This will increase the sympathetic stimulation of the SA node. And I'll talk about this in the next slide. Basically, this is called the atrial Bain bridge response. So Malak, let's go to the next one. Okay, so I kind of summed it up in a table. So basically, when the whole point of this response is to prevent overfilling of the atria, okay, and to maintain cardiac output. So what happens is that when there's increased atrial filling due to increased venous return, what will happen is that the atrial stretch receptors will sense this and send signals to the SA node, which will in turn increase the heart rate so that blood doesn't accumulate in the atria. Okay? So next one, please. Okay. So how could tachycardia be treated? Okay, no, Malak, it's not coffee. Yes, it is A. It's A. Calcium channel blockers. So what is tachycardia? Tachycardia is a very fast heart rate, a heart rate of more than 100 beats per minute. And you can, digitalis will increase contractility, remember? And thyroxine will also do the same thing, and epinephrine too. So they will just increase the strength of the contraction. The calcium channel blockers can reduce the heart rate. So let's go to the next slide. Okay, here. So there are certain chemicals that affect heart rate and also other factors. So we have chemicals like epinephrine, thyroxine, and the ion balance, most importantly, potassium and calcium. So when there is low calcium levels, the heart will be depressed. Okay. And when there is very, very high calcium levels, they can cause they can disrupt the heart function. They can cause arrhythmia, like abnormal rhythm. Okay. Then when there is a high level of potassium, it can lead to heart block and cardiac arrest. But when there's very low uh, potassium, it will lead to like reduced strength of the heart and like out of rhythm beating. We have age, gender, exercise, and body temperature. They will also affect the heart rate. I saw a question where there was like, what would not affect the heart rate or something, and it was like all of these options were listed, and then the last option was like skin color. So I didn't want to include that. It was very silly, but yeah. So tachycardia is, I explained it, it's heart rate. It's abnormal. It's more than 100 beats per minute. And when it's persistent, when it just keeps happening, it can lead to fibrillation. And bradycardia is slower than 60 beats per minute. Okay, and it can happen due to a lot of things like low body temperature, even drugs. Okay, so yeah, go. Okay. So question, multiple myocardial infarctions in a patient with congestive heart failure typically results in hmm. Any other answers? Guys, wake up, please. Okay, it's A. It's non-contractile scar tissues. Because what happens in myocardial infarctions is that the heart cells die, and we know that the heart cannot regenerate, right? So when you can't regenerate, they will just replace the tissues or the cells with fibrous scar tissues, and these are non-stretchy, right? And the whole point of the heart is to contract and all that. So yeah, it would be. It's not nice. Next one. Okay. So, what would happen if there is a disturbance in the amount of blood that returns to the heart and the amount of blood that is pumped out of the heart? This condition is called congestive heart failure, and it can happen due to like a variety of things. But the things mentioned in your books, I mentioned them here. So the first one is coronary atherosclerosis. This is basically fatty buildup in the coronary arteries. Coronary arteries, the arteries that supply blood to your heart, right? So when they have these fatty buildup, you can see in the picture that it kind of narrows down this vessel. Less blood reaches the heart, and therefore less oxygen reaches the heart. That can also lead to heart failure. There's less oxygen, the heart will not be able to pump properly. Then also persistent high pressure or hypertension. This will lead to the heart overworking because we said that the afterload here is high. So the muscle of the heart will eventually weaken. Okay, and then we have dilated cardiomyopathy. And this is when the reason for this is unknown, but this is basically when the ventricles stretch and they kind of become flabby. So the muscle, the myocardium, it kind of deteriorates in this case, so it will not be a good pump. Then we have multiple myocardial infarction, and this is where, like in the question, we said that scar tissue or fibrous tissue will replace dead heart cells. So pumping will not be effective because it cannot like stretch as much or contract as much, you know? So next one. Okay, question. A patient is experiencing difficulty breathing, coughing up frothy sputum. What would be the cause? The keyword here is difficulty breathing. Yes, exactly. It's left-sided heart failure. And I will explain in the next slide what that is. I have a drawing. Next one. Yes. Okay. So here we have right-sided heart failure. Okay. What happens is that in this case, the right ventricle will not be able to pump blood. So when blood is not pumped, what will happen? It will accumulate. When it accumulates, there's already venous supply to the heart that's coming from the left side, right? We said superior vena cava, inferior vena cava, they're all getting the blood to the heart, but the blood is not going anywhere from the heart. What happens is that it just gathers there. When it gathers there, it just starts like pushing, like the pressure in these venous points, it increases. So what happens when there's high pressure in these vessels? Molecules start to escape, or we can just say that plasma starts leaving through the little pores in these blood vessels. So when plasma leaves, there's something called edema, and this edema is peripheral. Okay, so in these patients you can see that they have swollen toes, they have swollen hands, swollen face. Okay, so you can see that. And then you can see in the left-sided heart failure, the blood comes from the pulmonary veins into the left atria, and when blood is not being pumped from the ventricle anywhere, this blood just stays in the ventricle. So when it stays and there's just more blood getting pumped because the lungs are still working, there's more blood coming. What will happen is that there will be increased pressure, like same mechanism here, but just in different places. So it will result in pulmonary edema. Yes, I'll show the question just in a bit. So it will result in pulmonary edema, okay, and this can lead to difficulty breathing because it's like pushing the lungs. So Malak, let's go back to the question. Where was it? Yeah. Is that good? Okay, I think we can move on. Okay. Okay, yeah. So we have another question, which is a 75-year-old man with a history of chronic heart failure presents with worsening shortness of breath, peripheral edema, and fatigue, shows severe ventricular dysfunction. The cardiologist explains that the heart is irreparably weakened. Which of the following is most appropriate for management? This question is basically about the treatment of heart failure. So here in this case, this man is not just experiencing one-sided heart failure, he's experiencing both. He's having both of the symptoms. So how could we treat this guy? Any answers? No. Try again. Should I just say? Okay, it's B. It's a diuretic, antihypertensive drug, and digitalis derivative. Now, diuretic, why? Because this guy is going to have edema. Okay, we have excess fluid in our tissues now, and we don't want it there. Diuretics, what they do is they flush out these fluids. Okay, so they get rid of the edema, or they at least reduce it. Second thing is antihypertensive drug. Now, antihypertensive, why? Because to reduce blood pressure. Okay, we want blood pressure to be reduced. Why? Because we want the ventricles to work less hard, right? In high blood pressure, the ventricles have to overcome, and that also leads to heart failure. So we will reduce that chance. Then also the digitalis derivative. This is a positive inotropic agent. It increases the amount of calcium. Um, it increases the contractility, and basically it's kind of like, you can think of it as it gives strength to the heart to pump. So if we go to the next one, I've written like treatment. Malak, next. Okay, yeah. So treatment, you can remove excess fluids with diuretics. You can reduce afterload with drugs that drive down blood pressure, and which are antihypertensive, you can say, and increasing contractility with digitalis drug. So I think that's all from me. You see, yeah.
Yeah, this is a graduation question that basically combines the cardiac cycle and whatever Zarlala just went through, the cardiac output and stuff. So I think because we already went very overtime, like 20 minutes overtime, we'll send you guys this presentation, and inshallah you can go through the question and do it yourself. And that's it for CVS Heart. If you guys have any questions, feel free to message me or Zarlala. And yeah, if you have questions now, we can stay for like 5 minutes and answer them. But that's all for CVS Heart.
And thank you guys for attending and participating.
Oh, yeah,
like Malak said, if any questions, just tell us either now or later.